Medical billing in the state of Arizona operates on a logic that is entirely distinct from the rest of the country. The primary driver is the Arizona Healthcare Cost Containment System, AHCCCS. It functions through a specific network of managed care organizations, each with its own rules and shifting timely filing windows. There is also the Industrial Commission of Arizona. They oversee workers' compensation using fee schedules and reporting requirements that are completely separate from commercial or government payers. Most billing staff are trained on national standards. While that foundation is necessary, it often fails to cover the state-specific documentation and MCO logic required for Arizona claims. This structural complexity creates a persistent administrative burden. It slows down cash flow and traps earned revenue in a cycle of rework, limiting a practice's ability to reinvest in growth. Arizona practices are facing these local hurdles at the same time a national wave of claim denials is hitting the industry. The American Hospital Association reported that in 2024, the average initial denial rate reached 11.8% industry-wide. To maintain a healthy revenue cycle, the HFMA benchmark suggests a denial rate below 5%. Most practices operate at double that threshold. When a claim is denied, it adds 15 to 30 days to accounts receivable, pushing 30-day revenue into the 60-day bucket. Once a claim sits for 120 days, the probability of collecting that money falls below 50%. While denials slow down cash flow, the long-term impact is more severe. They turn earned clinical revenue into unrecoverable permanent write-offs. The traditional approach is to keep billing in-house, where the average salary for a biller in Arizona is approximately $54,400 per year. Base salary is just the start. Adding taxes, benefits, software, and fees brings the fully loaded biller costs to $55,000 to $75,000 annually. MGMA shows a 33.3% turnover for billing staff. Replacing them costs $25,000 to $30,000 in lost productivity. This creates a staffing spiral. You spend months training a biller on Arizona-specific rules. They reach burnout within 18 months, and the practice is forced to start over. Maintaining an in-house team often means paying a $75,000 premium per seat for a model that is defined by its own fragility. There is also a technological shift to consider. Payers are now deploying automated, AI-driven auditing tools at scale. These automated systems flag medical necessity mismatches and prior authorization gaps faster and more frequently than a human team can monitor. A human biller working manually is effectively fighting an uphill battle against these relentless automated denial engines. It is no longer possible to solve the denial problem simply by hiring more people. The speed of automated audits requires a different level of technical intervention. To address both cost and complexity, top groups are moving to the dedicated outsourced specialist model. This is distinct from a generalist BPO. You aren't sending claims to a shared, rotating pool of staff handling hundreds of different accounts. Instead, a specific credentialed biller is assigned to your practice every day. They work directly inside your EMR, whether that is Epic, Athena, or NextGen, eliminating data lag and the need for exports. These specialists are AAPC or AHIMA-credentialed and operate under SOC 2 Type 2 and HITRUST compliance standards from day one. This model involves a clear trade-off. You exchange the physical presence of an employee in your office for a standardized, secure, and specialized remote team. Because this model is built on technology, your dedicated specialist uses AI-augmented tools to manage the daily workflow. Automated claim scrubbing identifies CPT and ICD-10 errors before the claim is submitted, preventing the payer's automated engines from triggering a denial. Smart routing also prioritizes the accounts receivable queue, focusing on claims with high timely filing risks to ensure they are worked before deadlines expire. The math behind this shift is straightforward. A dedicated specialist seat costs $399 per week, compared to the $75,000 fully loaded in-house floor. This totals approximately $20,700 per year, a 72% reduction in fixed overhead for each billing position. Reclaiming that capital allows a practice to stop funding administrative turnover and start reallocating those resources to clinical care and expansion. The transition period is 14 days. The first week is dedicated to secure access and setup, followed by active billing operations in week 2. This change requires administrators to shift their focus. Rather than managing a local staff, they monitor performance through weekly KPI dashboards, tracking throughput and resolve rates. To ensure the model works for your specific practice, the engagement begins with a 14-day risk-free pilot, followed by month-to-month accountability.